My goodness. Wow, you missed us. All right, this is wonderful. We'll just give everybody a few minutes to join, get settled in. We see people are connecting, so we'll just give it another minute or so.
Got a full house.
Indeed, we do. Okay. All right, I think we'll get started. So thank you, everybody, for turning in this evening. We're very happy to be back with our September PEP Talk. We missed you last month, but we're back into our educating patient topics. And tonight we have just an amazing discussion ahead of us. Anticoagulants, the past, the present, and the future, what every patient needs to know. We are joined this evening by Dr. Gary Raskob. Dr. Raskob is the Senior Vice President and Provost, Regents Professor, Epidemiology and Medicine at the University of Oklahoma Health Sciences Center. He's also a member of the National Blood Clot Alliance Board of Directors with myself and Todd. So Gary, thank you for joining. And he is, and I say this with love in my heart, a pioneer in the industry. And so we are going to kick it off with Gary leading the charge here. But Gary, before you get into your presentation, I thought perhaps you could share with the audience your background and your history, because you've really been on the forefront of so many changes in the anticoagulation space.
Great. Well, thank you, Leslie. Thank you for the invitation and the opportunity to speak with all of you this evening. It's been a pleasure to be engaged with NBCA over the years, and I think the work that you're all doing is really crucial, and the patient voice is critical to us being able to continue to advance this field and to help further advances and policies to reduce the burden of this problem in our population health. I, interestingly, my academic background is in clinical pharmacology and clinical trials, methods, and conduct and design. I've been involved in research in the anticoagulant area since 1978. And I became involved in this, interestingly, as a high school student in Canada, where I received a small award from the Ontario Heart Foundation to become exposed to medical research, which I was interested in at the time. I worked for a summer in the lab and program of Dr. Jack Hirsch at McMaster University, who many of you will know is one of the icons in developing the whole field of deep vein thrombosis, pulmonary embolism research. And I worked there and did graduate study at McMaster University and worked with Dr. Russell Hull on a very regular daily basis in many of the early clinical trials. And I completed my doctorate at University of Oklahoma, and then began my academic career in clinical research in thrombosis treatment and prevention, particularly deep vein thrombosis treatment and prevention, and the development of new anticoagulant drugs. And that's been my passion for about 30 years. I had the great fortune to work with a number of colleagues very closely. Some of you probably heard on this forum before, and on many clinical trials. So over the last 15 years or so, I've been involved as either the chair or a steering committee member for 9 phase 3 studies of registration of new anticoagulants, including the studies that led to registration and approval of rivaroxaban, apixaban, and edoxaban for the treatment of deep vein thrombosis and pulmonary embolism. I led the trial of edoxaban for the treatment of cancer-associated thrombosis, and the study of rivaroxaban for prevention in after hospital in high-risk medical patients. And so, phase 2 and 3 clinical trials and advancing these new anticoagulants to FDA approval and application has been the focus of my scholarly career.
Great. Thank you, Gary. Okay. So we're going to try to make this not like science class and interactive. It's a complicated space. And so Todd and I may put the brakes on occasionally to ask you to back up and just to re-explain things for the benefit of everybody, myself included.
Yeah.
So
Me
why
too.
don't you go ahead and share your
Okay.
screen?
Good. All right. Yes, in doing this, and when Leslie asked me to take this on, whoops, what's happening? Bear with me, something technical happened in the interim, Leslie.
That's okay. We can always.
Here we go. Okay. Understand why that. Bear with
If
me.
you want, we can go back to controlling the slides.
No, I'm good. Here, we'll do it right now. There was one thing that I needed to turn off from before. Okay. So by way of background, more than 1 in 4 people in the world die from blood clot events. Blood clots can involve the circulation of the arteries, which take blood away from the heart and to the organs, or of the veins, which bring blood back from either the organs or your legs and arms to the heart. And a blood clot is the final common pathway of most heart attacks, most strokes in the United States and developing world, and developed world, and of course, pulmonary embolism and deep vein thrombosis. And so you see some statistics here from the World Health Organization and what's called the Global Burden of Disease Program, which does an assessment of causes of death around the world in over 180 countries every sort of 5 years. And you see that 5 million people die from stroke every year. Heart attacks due to blood clots. Ischemic means lack of blood flow. So heart attacks due to a blood clot kills 1 in 4, and strokes kill 1 in 4 people. Atrial fibrillation really increases the risk of stroke. And then we add pulmonary embolism and deep vein thrombosis as leading causes of death in the United States and in Europe. These are the best numbers we have, about 300,000 per year in the United States, up to that, and over 500,000 in Europe. And a very important emerging area, which I'll talk about later, are the complication of blood clots in cancer patients, because as we get better and better at treating and often curing cancer now, more patients survive to experience a blood clot as a complication. And some of the new drugs in cancer treatment have as a side effect causing blood clots.
Gary, I saw that the number may be as high as 9 times. Is that correct?
Yep.
A ninefold.
Sure. Yeah. Depending on the type of cancer, the age of the patient, the treatment they're getting, the extent of disease. So there's a lot of variables that go into it. Yeah.
Mhm.
But definitely an important area. In our work, we just demonstrated that cancer-associated thrombosis contributes about 20% of all the cases of deep vein thrombosis and pulmonary embolism that we have. Okay,
That's
so it's
amazing.
1 in 5.
Wow.
So anticoagulant drugs are the mainstay for preventing and treating thrombosis and its complications, right? Thrombosis, a blood clot. Embolism is when a clot travels in the circulation. We were talking earlier, Todd, so anticoagulants are critical. Aspirin has had a useful role in people with blood clots in the coronary arteries, the heart arteries, or the neck arteries in the brain, stroke, and so on, but really does not have an ongoing significant role in deep vein thrombosis or pulmonary embolism. So more for arterial blood clots. I think we will learn over the next few years that we're going to try and get aspirin. There are other drugs that do the same thing of aspirin, which may have a bit less bleeding and are more potent and that are better to combine with anticoagulants. So I would predict that you'll see over the next 5 years or so, aspirin go to the wayside as a thrombosis prevention medication.
Hey, Gary, if I can just throw in there. So thanks for confirming that, number one, because we do have a lot of patients that think that, they're told that, hey, to prevent further deep vein thrombosis, just go on an aspirin. And I've always, tried to guide people, and you've got to put more into that, right? With the risk factors and the preventive measures, good blood flow stimulation, staying hydrated, keeping an ideal healthy weight. You just can't rely on aspirin for that anyway. But thank you for pointing out that it's more beneficial for the arterial. What about people that are on aspirin and an anticoagulant? Because you see a lot of patients that are prescribed both. Why is that?
Yeah. So first thing, it reminds me to say, please, all the patients on the call tonight, don't use anything I say tonight as the basis for stopping one of your medicines. Okay.
That's right.
Every individual, that's why we have a doctor, and you have to, we're giving generalities and core information, but every individual is different and has certain things. Okay. Now, we learned over the years that particularly in the case of stroke prevention and in the treatment of heart attacks and in people who get stents put in their heart, that when we give both a antiplatelet drug like aspirin, which affects the platelet clotting cells in the blood, and an anticoagulant, we have better results. Okay. But we also increase bleeding complications, which is the theme of this slide. The one thing I do want to just mention, there is one role still where some people will be recommended to get aspirin, and that's if you people who are having a hip or knee replacement. The orthopedists still like to use that. After 30 years, I've not been able to convince them. And they believe the aspirin studies. The key thing is aspirin is probably okay for prevention in people who've never had a DVT and are having, say, a knee replacement, providing you get an anticoagulant for the first 4 or 5 days and then go on to aspirin as an outpatient. Okay. That's the one area. Although I'll just say, if I was having my knee replacement, that's not what I would do. I would do one of the DOACs because there's no evidence, no good scientific evidence that aspirin in that context is safer with less bleeding than a DOAC. That's the fallacy that I think even some physicians still have. Okay. So that leads me to the linkage, which is anticoagulants have been profound in the benefit that they've given patients, but its benefit and its impact on population health is still limited significantly by the side effect of bleeding. Most of our anticoagulants don't have other major side effects now, the oral ones particularly, but bleeding is the determinant of risk in the risk-benefit equation. And bleeding, the risk of bleeding has led some physicians not to prescribe anticoagulants when they should. And that's an important issue. So the whole search now is to try and reduce the side effects of bleeding. What we call the direct oral anticoagulants, or you'll hear the term DOACs, are a major improvement over the older drugs, warfarin being the main one in the United States. For 60 or 70 years, warfarin was the only oral anticoagulant drug we had to use in the United States. And then the DOACs came in. These are called vitamin K antagonist, because that's how warfarin works. It works in your liver to stop the synthesis of vitamin K and blocks vitamin K, which is needed for active clotting factors that are made in your liver. Okay, so the DOACs are a major advance. So I'll come to the chat. There's a good question in the chat in a minute here. But
before you, just a quick question,
Yep.
before you move forward. So the DOACs came out when?
I think into clinical use 2011, 2012.
And has there been any update since then, or are we embarking on the new update now?
I mean, there have been studies since then, incrementally about the role of DOACs and how to use those in various patient subgroups. And Tracy has asked, she said she was on warfarin for 21 years. Doctors told her to add a baby aspirin, 81 milligrams, and then she had a GI bleed. And that can happen when we use aspirin and warfarin together. We increase the risk of bleeding. GI bleeding is possible. And now on Eliquis and no aspirin. And that's, I don't know your situation, Tracy, but I would follow their advice. And again, where I think we're heading is if we can get away, we're going to have to use anticoagulants and antiplatelet drugs together in some settings, but there are newer drugs than aspirin, and which will be better for combining. Okay. So very interesting. So just to show you what a major advance the DOACs were, the two places where they were initially used and entered into clinical use were in prevention of stroke in people with atrial fibrillation and in treatment of deep vein thrombosis and pulmonary embolism. In the case of atrial fibrillation and stroke prevention, they led to a major reduction, 19% in stroke events in those patients compared to warfarin, 52% in hemorrhagic bleeding strokes or intracranial bleeding as a side effect. This is the most worrisome bleeding event that you could have. And we cut that in half by using a DOAC compared to warfarin. And the data says that overall, using DOACs instead of warfarin led to a 10% reduction in death from any cause. So very major benefits in the stroke prevention area. In the deep vein thrombosis treatment area, the drugs were shown to be as good as conventional treatment with Lovenox and warfarin, but led to a major reduction in bleeding, including major bleeding. So again, the DOACs did produce a major safety advantage in reduced bleeding. And of course, were a lot easier to use than warfarin because you don't have to go get your blood taken and adjusted on a regular basis. And they had much less drug interactions than warfarin and less food interactions. And so those things, they were just much easier to use clinically, and they had these major benefits. And so they really took over the space with some rare exceptions, okay? So if we think about anticoagulation now, the drugs that we've had and used, and what are the unmet needs? Well, heparin and the low molecular weight heparin, Lovenox, still have important roles, but they have to be injected parenteral. That means injectable. Warfarin, very high variability between patients. No two patients are the same. Lots of drug interactions, very narrow therapeutic range that you have to adjust the INR to. Half of the major bleeding events on warfarin happen while the person's in the therapeutic range. So that's a big challenge. Major bleeding and intracranial bleeding despite INR and therapeutic range. So Todd, maybe now is the time to define what we mean by major bleeding.
Yeah.
That's a big question that comes up. People get a bump on the head and they worry because their doctor always tells them, if you get hit on the head, go to the ER. They tend to always say that, but then the question comes from patients, well, how, do I just raised up too quick and I bumped my head on the freezer door.
Yeah.
right? Do I need to go to the ER? So there's, there's a lot of discrepancy in there. So yeah, talk a little bit about what is major bleeding.
Okay.
And maybe you can even touch on what kind of signs can somebody look for when it comes to major bleeding.
Right. So the first thing is, these are terms we use in clinical research. I wouldn't minimize anybody's bleeding, right? You have bleeding, you have a toilet bowl full of blood. That's kind of scary. And or you vomit blood or you do something like that. That's important to the patient. So please don't take these terms as minimizing any type of bleeding for anybody.
Sure.
I've had it, my spouse has had it, it's scary. We've used these terms as ways of categorizing events from a risk-benefit calculation type of thing, okay? So when we say major bleeding, we use the criteria, well, there are a number of criteria, but the ones that are most commonly used are by the International Society of Thrombosis and Hemostasis, which is bleeding that leads to the need for transfusion of 2 or more units of blood. First of all, there should be overt bleeding. That means you have vomited blood, you have blood in your urine, you have blood in the stool or in the toilet bowl, you have other visible signs of bleeding. If you need a transfusion of 2 or more units, if your hemoglobin's gone down by 2 units, if it is in the brain, inside intracranial, any bleeding in the head is a problem because it has nowhere to go. It's contained by the skull, and that leads to serious complications. If it's internal in the GI, in behind the kidneys or other places, these are major bleeding events. If it requires surgery or reoperation, those are what we call major bleeding. Otherwise, we'll call it minor bleeding, but it's not minor to the patient. It's still, well, the term nowadays is clinically relevant non-major because we wanted to get away from the word minor, okay?
Right.
Because it's still important to the person. Now, to the issue of banging your head. The problem with that is that people can bang their head, not have any symptoms while the bleeding is small, but as it grows inside the head and begins to displace or compress the brain, then symptoms can occur, by which time it may be too late. So a big hematoma inside the head could take 24 to 48 hours to evolve, but you don't want that to happen. That's why the advice is, if you're on anticoagulants and you bang your head, you bump your head, go to the ER. I would agree with that 100%. I would do that myself. We can do imaging, we can see, we can follow you, we can watch. Be safe. Don't be sorry later by not getting it investigated, okay? And it may not manifest itself right away. With the DOACs, we still have some bleeding, even though it's less than warfarin. We still have 2 to 3% per year in atrial fibrillation. This has led to underuse. So doctors say, well, I'm real worried about the bleeding. Well, then they put the patient at risk of stroke by not anticoagulating, okay? In the GI, in cancer area, in people with deep vein thrombosis and pulmonary embolism associated with GI cancer, the DOACs actually increased the bleeding compared to low molecular weight heparin injections. And some groups still, we don't use the DOACs. Mechanical heart valves, the antiphospholipid syndrome, or severe renal impairment, those people still need to take warfarin. So there's still, despite the advances, room for major improvement, and the focus is going to be on reducing bleeding, okay? Any questions on this part? Yeah.
Gary, just for the benefit of some of the patients who ask, can you explain what GI bleeding is?
Yes, gastrointestinal bleeding, bleeding in your stomach or small intestine or colon, goes into 2 types. Upper GI bleeding would be manifest by 2 main symptoms: presentations. One is if you vomit red blood, that would be upper GI bleeding. Or if you have a black tarry stool, like I mean really black like tar, that's because the blood, as it passes through the rest of the system, gets digested, so it changes color and everything, right? If you see, the bloody, you go to have a bowel movement and there's bloody red blood in the toilet bowl, that's probably lower GI bleeding from the colon or somewhere there. Maybe there's a polyp or something that is bled. And so bleeding in your stomach, small intestine, or colon, and categorize as upper or lower. And so what we saw was in the patients with cancer of the stomach or even the colon, that the DOACs increased bleeding in those people, and most of it was due to the GI, the gastrointestinal type of bleeding.
Okay, hey Gary, just a couple of quick questions regarding warfarin. I'll give them to you separately, but first of all, we do have patients who just wonder what INR stands for.
Yep.
What role does that play with warfarin? Could you explain that?
Yeah, so when you take warfarin, we can't just give a fixed dose because everybody reacts differently and there's huge variability between people. So we have to draw your blood and do a test in the lab called the prothrombin time. And then based on that lab test, it's converted to a number called the INR. INR stands for the International Normalized Ratio. The reason that is that different labs can use different chemicals for measuring this prothrombin time. And in order to get to a standard language around the world about these drugs like warfarin, we use a thing called the INR. So when you take warfarin for most indications, deep vein thrombosis, pulmonary embolism for sure, we want the INR number to be between 2 and 3. Okay, it's just a measurement made from a lab test to tell the doctor to increase or decrease your dose of warfarin.
Okay, thanks, Gary. You pretty much answered both questions, so thanks.
Good. Okay. The next 3 slides are have the risk of being kind of scientifically geeky for you all, but I'll ask you just bear with me for a minute. I'll do this the best I can. And if you understand this, then you will understand the whole future and basis of where anticoagulant therapy is going in the future for whatever condition. Okay. So why does our blood clot? Well, we have 2 processes. Hemostasis on the left side of the slide is the normal response that we have to protect us if we cut ourselves or get injured so that we don't bleed to death, right? We need our blood to carry oxygen and be there. And so we have a built-in mechanisms to protect us. Thrombosis is the abnormal or pathologic process when blood clotting goes awry. Okay, that's point number 1. Now, hemostasis generally occurs outside of or initiates outside of the blood vessel to produce a plug or a clot of a cut blood vessel or blood vessels. Whereas thrombosis occurs inside the blood vessel to lead to obstruction and or traveling of that clot to lead to obstruction elsewhere of the circulation. Okay, we want this hemostasis process to go on because it stops us from bleeding. We don't want this thrombosis process. Now, throughout my whole career, the holy grail of research has been to try to find a drug that will stop thrombosis but not impair the normal process of blood clotting. If you cut yourself shaving, or if you have an injury, or a woman has a normal menstrual period, we don't want excessive issues there, but we want to stop thrombosis. Now, blood clotting occurs in our blood by a series of reactions, chemical reactions of pre-existing proteins that are in our blood. Our liver makes these proteins and they circulate around in our blood, and they are activated under certain circumstances. So if we have an injury, let's say you cut yourself while you're making your salad for dinner tonight, that leads to initiation of this process of hemostasis by the coming into contact of a substance called tissue factor, which is in our tissues surrounding the blood vessels. When that contacts with blood, it activates a protein in our blood called factor 7. That activates a protein called factor 10. That activates another protein, thrombin, which activates another one, and leads to formation of a clot. Fibrin is the final step. And you know, when you look at, you have a clot or whatever, and you can dab it, and then you see a little straw-colored substance there, and you wipe that maybe away and it bleeds again. That's the sort of initial consolidated clot occurring due to this process of what's called the extrinsic system. But that's not enough to be strong enough to seal that wound. So we have more to this process, which I'll talk about in a moment. The key thing to take away, if you learn nothing else from this talk and want to know what's the big excitement about anticoagulation, is that for a large amount of research, which I'm trying and just summarize very briefly for you, is factor 11 is very important to the process of thrombosis and development of a clot inside the vessel, but we don't need it for this hemostasis process. So factor 11 is important to pathology, thrombosis, but not to normal hemostasis. And so that makes it an interesting target to interrupt the clotting process, because it should keep our ability to seal wounds and other things intact. So now in a little more detail, when we cut ourselves, as I told you, tissue factor activates clotting factor 7, and that leads to the formation of a clot here through factor 10. Factor 5 is a cofactor in this process. That's why people with factor 5 Leiden have an interrupted abnormal thrombosis process. And we get an unstable clot. Tissue factor and 7 together, this step here also activates factor 9 in the so-called intrinsic system here. So there are some other proteins here, and tissue factor can also activate that, and then that leads to a bit of amplification. This pathway is stronger and faster, and then leads to leads to this process being amplified to a stable clot. And then when we have enough thrombin formed, thrombin feeds back and activates factor 11 to drive the process even further. So this is like an amplification process where a little bit produced first feeds back and has these loops that makes it stronger and faster to create this consolidated clot to seal a wound, okay? The importance of this process is clearly established by the fact that people who have deficiency of factor 8, that's called hemophilia A, or factor 9, that's called hemophilia B, they have serious spontaneous bleeding. They bleed with no injury. They can bleed into their joints. They can bleed into their brain and other things. People who have deficiency of factor 11 don't have that same spontaneous bleeding. And that was observed by studying genetic deficiency of 11. So this is the process for hemostasis. And you can see that we don't need factor 11 completely to make this happen, because by activating 9, it accelerates this process, and we don't need to go to the 11 step. Now, in thrombosis, thrombosis is caused by two things: either a arterial or a venous clot, where tissue factor perhaps released from you've probably heard of plaques in your arteries, narrowing of the coronary arteries. They can rupture and release tissue factor, or cancer can release substances that activates the clotting system here. And we get an initial process where we produce a little bit of thrombin, but that feeds back, or together with DNA, RNA released from, for example, cancer cells that are being killed by chemotherapy, whatever, this feeds back and activates this process through factor 11, and we get a clot inside the vessel. Or whenever we induce a foreign surface into your circulation, a catheter or a heart valve or any substance that we expose, a bypass graft in an artery where blood touches that surface activates blood clotting here in the intrinsic system through factor 12, 11, and activates this system and leads a clot around a foreign surface like a catheter, okay? So the key idea is that if we can target and interrupt factor 11, we can shut off or mitigate the thrombosis process, however it's induced, but we will keep this process needed to prevent bleeding events. For example, we have a polyp in our GI system, or you cut yourself or something. We can keep this defensive process intact for us, and if we are targeting factor 11, which is not the case for the DOACs, because the DOACs target factor 10, which is common to both pathways. Okay, so I know that's a lot, that's complicated. I'll stop for a minute and see if there are any questions on this part. Again, the key thing, factor 11 is really important for the process of thrombosis, but it's not needed to create adequate hemostasis. And that's what led a lot of people. And then we have 3 lines of evidence, which has then led to a number of companies really pursuing this. The first is from genetic epidemiology. When we look at large cohort studies, if you measure people's factor 11 and then follow them for years going forward, people, even within the normal range of factor 11, if you have high levels, you have a higher risk of stroke or DVT events than if you have low normal levels. So that's a very important piece of information. Secondly, the people who have inherited deficiency of factor 11, which occurs commonly in the Ashkenazi Jewish population, they have little or no risk of serious spontaneous bleeding and reduced thrombosis risk. So the inherited deficiency supports the concept that factor 11 isn't needed for hemostasis. And then experimental animal studies where we can manipulate the 11 levels and so on and lead to thrombosis also support these concepts. So I'll stop there. Question, Leslie.
Just, I had a question from somebody who just messaged me, wanted to know about, I know we're going to get into this a little bit, the timeline of these new drugs that are coming out, because they're still in trial.
Yep.
And
so,
what is the timeline associated with all of these drugs?
Right. So we've had a number of them that have now finished FDA phase 2. And we'll be pursuing phase 3. So you're probably looking at a 2 to 3 year period for the phase 3 studies. Of course, they all won't be done in every possible indication all at once, but I think you'll see multiple phase 3 studies starting. One is underway, which I'm going to talk to you about. The Aster and Magnolia studies, 2 are underway. So you're looking at a 2 to 3 year time frame to complete the phase 3 studies, and then depending anywhere from a 6-month to a 12-month FDA review time. Okay, my bet is most of these will get what's called fast track review, which is a 6-month time, by which FDA has to give an answer to the sponsor. So you're looking at 3.5 to 4 years optimistically to see these on the market. Okay.
Okay, great.
So Gary,
And that assumes the results are favorable of the phase 3 studies, of course.
so in the meantime, Gary, for those of us on the newer DOACs, they're not exactly new anymore. I've been on Xarelto since 2011, so I don't consider it very new anymore. But you had mentioned last year, or maybe a little earlier, about a possible reversal, because right now all that's available is Andexxa, and I think that's the name. And it's not in all hospitals because it's super expensive.
Yeah.
On that reversal you had mentioned before.
Yeah. So Andexanet is very expensive, and the data show pretty sparse use throughout the United States because of that. There is a product, Siraparentag, which is undergoing some clinical studies, which is a small molecule, will be much less expensive and easy to apply, but it hasn't proceeded into phase 3 yet. And that's been delayed a little bit because it was being run by a company that was then bought, and then another company bought that company. So it's undergoing those processes, but again, they would have to do some phase 3 studies to show the benefit. Now, there are some other studies going on with other reversal strategies, the factor concentrates, the 4-factor concentrates, and so on, compared to Andexanet in people with serious intracranial bleeding. So still a little bit of time to wait and see if we can get a simple small molecule to reverse either Eliquis or Xarelto.
Before we move forward into strategies, we do have some questions in the chat.
Yep.
Tracy asked, can doctors test for factor 11? Should we be asking for a factor 11 test?
Yes, they can. No, you shouldn't routinely unless you have a symptom or a special reason. I mean, if you have spontaneous bleeding off of anticoagulation or something like that, then, or if you have a family history of that, or you're in the population, then yes, but not routinely now if you don't have any problems.
Okay. And then coming back to the, and I know all of us as patients have a great concern about this, but Lisa wanted to ask, can you address the chat question about guidance again as to how hard you have to hit your head before you go to the emergency room? So,
Yep.
This is one of my big fears. This is, big fear of most patients. And so can you just kind of ballpark us a little bit, understanding that we're not asking you for medical advice. We're not giving medical advice, but I think it's a little bit confusing for people.
If I'm on, again, I would have a low threshold myself, because, well, I would have, if I was on anticoagulants and I bumped my head, I would have a low threshold for going and getting checked. Doesn't necessarily mean you'll have to get imaging every time, but I would go have a doctor see me and look at it, examine me, do those things, because bleeding into the brain is so devastating and sometimes irreversible. So I would have a low threshold to, and certainly if it was a substantive bump, I would want to be sure I had imaging done, like a CT or an MRI, right? But that's partly my threshold is very low because I see a lot of these cases and hear about it, and it's tragic. I just can't give any more clear
Okay, so
specifics
better
on
safe
it.
than sorry. If you have any,
Yes,
any
absolutely.
concerns, just find your way to the emergency room.
Yeah. Yeah.
Okay.
And they can examine you and they'll triage, get a qualified, experienced physician to do that for you.
Okay. And
then
then
you can
one
sleep
more,
better. Yeah.
one more before we move forward. So Kristen asked, if you have factor 5 Leiden, should we still be focused on targeting factor 11?
It's a great question. And there's no reason to think that factor 11 won't work in people who have factor 5 Leiden. But it's a great question, and we'll hopefully be able to discern that definitively in the studies.
Okay, thanks. Okay, we will address everybody's questions. It may not be tonight, but we will address everyone's questions. But in the interest of time, let's move forward because we're a little bit behind schedule now. So let's talk strategies to target.
Yeah, there's three main strategies. One is to reduce the synthesis of factor 11 in the liver. That's through a thing called oligonucleotides. What all this means is they are small chunks of DNA or RNA that get injected, and then they get taken up in the liver cells that make the factor 11, and they lead to a reduced synthesis. That's a product of a company called Ionis. That will have limited uses because it takes probably 3 weeks to a month to have its onset of action, because the regular 11 has to clear from the circulation. So that will have only occasional use, but will not be able to use to treat acute thrombosis or timely use in prevention. So the real strategies are going to be either antibodies, which will be administered intravenously or subcutaneously. They bind to the factor 11 and either and block it, either its activation or its activity. All of these clotting proteins that I showed you, the numbers 7, 11, 10, all of those, they circulate in our blood in an inactive state, and they get activated to an active state. And we can block either of those. So the two antibodies that have been studied and up through phase 2 are osocimab or abelacimab. Abelacimab blocks, interestingly, both 11 and activated 11. So it's very interesting. Small molecules, which can be given orally, they bind to the site of the activated 11 protein and stop its activity. They are reversible. And so the two that have gone farthest so far in development is milvexian and asundexian. Okay, these will be small drugs, oral medications like apixaban, for example, that will be given once or twice a day. The antibodies will be given either by intravenous or more commonly ongoing by subcutaneous injection. In the case of abelacimab, it's going to be subcutaneous injection once a month.
Okay. Is there any significant, for the small molecules, is there any significant difference between the two?
Not that we know of yet. So. Okay. So those are the strategies right now. I'll show you some information from 2 studies, one with the antibody abelacimab, which I've had the privilege to be part of the team working on this, and the other will be with the drug asundexian. As many of you know, a lot of the phase 2 studies with these new anticoagulants happen in people undergoing a knee replacement. Arthroplasty is the fancy word for knee replacement. Because we can measure the presence or absence of a clot in the veins by a venogram and get an idea about whether the drug is working. So we did a study of about 400 patients. They had their knee replacement surgery done, and then in the first day post-operatively, usually 12 to 24 hours post-operatively, they either were given enoxaparin, Lovenox, 40 milligrams subcutaneously once a day, or they received abelacimab as a one-time intravenous short infusion. Okay, then all people were followed for 10 plus or minus 2 days and had a venogram done. Some of you may have had that before.
Sure.
Fortunately, we don't use it all that much now, except in this indication here, because ultrasound is not so good for picking up clots that don't have symptoms, and we can use this to look for differences in the doses. Okay, so there were 3 doses of the antibody abelacimab, 150, 75, 30, and then the enoxaparin. And we did the venogram on all patients, and we also assessed them for any bleeding complications. So what was observed is that there was a reduction in a deep vein thrombosis with the antibody against factor 11 abelacimab compared to the standard care of enoxaparin, which is the standard approach for many hospitals. And particularly for these 2 doses, it reduced it from 22%, which is still common. So that's interesting. 22% of people getting knee replacement when we do a venogram still have a measurable clot. So we reduced that to 5 or 4% with these doses, 13% with the lower dose. Okay, so that's
really amazing.
Yeah, that's exciting change. And bleeding was low and only included 2 patients in these groups and none in the 150 milligrams. So this is probably random variation, but we can say that we had a more effective prevention without importantly increasing the bleeding. Okay, now that's important because what we're saying is we haven't shown it, there's no increase in bleeding. What we hope is as we go to bigger studies going forward, we'll actually show a less bleeding when we compare it against the DOAC, okay, or against low molecular weight heparin, particularly against the DOAC. So very effective, exciting reduction in thrombosis.
Yeah, no, this is exciting.
There are 2 phase 2 studies with the oral drug milvexian. One has been published in the New England Journal of Medicine. Also, a knee replacement study showed very similar results to what I just showed you. And there's a stroke TIA study that was just discussed at the European Society of Cardiology. And then there are 3 studies with the oral drug asundexian called the Pacific program. There's a stroke study, a study in atrial fibrillation patients, and a study after acute myocardial infarction, heart attack. And the atrial fibrillation study has been published in the Lancet, and I'm going to show you that was a 750 patient trial. And I'll acknowledge and thank the Duke group who coordinated this trial. This was a prospective randomized double-blind trial comparing people who have atrial fibrillation who got apixaban, Eliquis, which is the most commonly prescribed DOAC for atrial fibrillation, or 2 doses of the oral 11 inhibitor asundexian, and they got that for 12 weeks, and in a double blind, so nobody knew which drug the patient was getting, and the primary focus was on the safety to look at the bleeding outcomes of major and non-major clinically relevant bleeding. And what we saw was that the doses of the 11 inhibitor here, 20, 50, or pooled, resulted in less bleeding than apixaban, and that was clear for all bleeding events, and for about a 60% reduction or so in 50 to 60 in minor bleeding, and even major bleeding was showing a trend. So this was the composite of major and clinically relevant had a clear reduction. This data was the first time that we saw that the factor 11 showed less bleeding in a head-to-head small study with apixaban, okay? And then all the other phase 2 studies that I mentioned showed no increase in bleeding. So we've got now 5 or 6 phase 2 trials, which clearly show that factor 11's inhibitors either do not increase or had in one study less bleeding. And so that's led to the excitement to go forward with the phase 3 studies.
So Gary, I
yeah.
have another question from somebody that has come in.
Yeah, good.
Which is, do you anticipate that these new drugs will retire the existing DOACs in the next 4 years or so?
No, there's no way we'll be able to get to all the indications that quickly, right? And we have to see whether they work or not. So that's a great segue. You know, these are the possible areas that I think the sponsors will pursue regarding the factor 11. For sure, I think we'll see prevention of stroke in AF patients, particularly trying to select patients at higher risk of bleeding. If you're a low risk of bleeding patient, DOAC will be just fine for you, and your risk of bleeding is quite low. But if you're in the higher risk category, that's where you could, and so I think they'll try and select patients there. Prevention of MACEs, major adverse cardiovascular events, prevention of heart attack and stroke and other events in people with end-stage renal disease, who may or may not also have atrial fibrillation. This is a challenging population with very high risk of heart attack and stroke events, but it's crying out for a greater need because those people have a pretty high risk of bleeding. Again, what's been studied in phase 2, a safer way to combine an anticoagulant with an antiplatelet drug in people with acute coronary syndromes, threatened heart attacks. Maybe it's common for those people to get a catheterization and a stent, and then they have to go on antiplatelet drugs. And then if you add on the factor 11 inhibitor, do we get a benefit? So I'm sure they'll go there. Prevention of recurrent stroke may or may not be pursued. Prevention or treatment of cancer-associated venous thromboembolism, this is being pursued. And I'll talk about that in a moment. And then prevention of remember I showed you about when we induce a foreign surface in the blood, so a catheter or a left ventricular assist device or a mechanical heart valve, factor 11s may be helpful there. I think that will be after we see some success in atrial fibrillation, VTE, maybe the antiplatelet coronary area, okay? Maybe not. Or the stroke prevention. So the different sponsors will make different decisions about where they want to go first with these things. I think most of them will go to the AF. Really privileged to be collaborating with Anthos Therapeutics, which is the only sponsor that is pursuing the deep vein thrombosis and pulmonary embolism area originally, and focusing on cancer-associated VTE to start, because that is the place with the highest risk of bleeding that we want to test whether there's a benefit of a factor 11. So there are 2 trials that are now launched and beginning to enroll patients, the Aster and the Magnolia studies. And they're very, very similar. Basically, they have the same designs. They're randomized trials where the therapeutic drug is the antibody abelacimab. That will be given for the first dose because these people have acute deep vein thrombosis or pulmonary embolism. They'll get a short IV infusion for the first dose, and then they'll get once-a-month injections for 6 months after that, okay? So that's very interesting way to give anticoagulation. And the reason we have two studies is because currently the guidelines say that the GI cancers should be treated differently because of their high risk of bleeding. The GI, gastrointestinal, or possibly the cancers of the bladder and the genitourinary system, they bleed more. And so there, the guidelines say they should use low molecular weight heparin for treating those people. But everybody else, all other cancers, typically would get apixaban, Eliquis as their treatment. So we're going head to head against apixaban in one study, in the Aster study, where people will get 6 months of treatment, double, in this trial with blinded adjudication of the endpoints. And then in the other study, it'll be abelacimab compared with daily injections of the low molecular weight heparin, which is the guideline recommended approach for gastrointestinal or genitourinary cancers. That's the Magnolia studies. We hope that these two trials will lead to great blooms of these flowers and have wonderful results to test our concept. Both of them are looking for less bleeding. Clearly here, even if we get no increase in bleeding, maybe we get even a better efficacy, because a lot of patients give up on taking once a day low molecular weight heparin. It's hard to do that for 6 months.
Sure.
Inject yourself. If we could replace a daily injection with an injection once a month, I think that's a winner, even if we don't get reduced bleeding, right? Here, we really want to see a reduction in bleeding against apixaban. And again, I think if we can reduce bleeding in this context, we'll have improved the care even further. So that's
let
what's
me see
happening.
if I can summarize this a little bit. So there are several new drugs coming down the pike. It's going to be focused mostly right now on the high-risk patient. The only sponsor right now is Anthos, who's focused on the VTE space,
Yes.
but still mostly cancer-related. The hope is down the road, these all show great efficacy, lower bleeding risk, and perhaps in the not too distant future, we might, those of us that are on a DOAC, that maybe this will be the new potential treatment for patients.
Yeah.
Lower risk, as good, if not better safety, but it's a few years down the road. If I'm summarizing correctly. Question for you, Gary. Shared decision-making is really important between patient and healthcare provider. What should be the conversation now with patients to introduce this to their doctors?
About these new factor 11 inhibitors?
Yes, about the new factor 11.
Probably not much, other than if you are in one of these groups. I think if you're already on an anticoagulation, and if you're already on a DOAC and you're having a problems or an event, then that's going to be a different situation than what the trials are really looking at the moment. I would say if you have cancer-associated VTE, you develop a cancer-associated VTE, you could ask if you would like to participate in a trial. I think the conversation would be more about access to the trial if you'd like to be a participant.
Okay.
But beyond that, the drugs won't be available right now. Yeah.
So Gary, do you have any information on possible generics? Because we hear a lot, obviously warfarin is dirt cheap in comparison with DOACs like Xarelto and Eliquis. Any generics on the horizon? Is there any way to get the cost down for people? Because a lot of people stick with warfarin because that's what they can afford.
Yeah. Right. Yeah. Generic DOACs are on the horizon. I don't know the exact timing of when that would happen, and the patent expirations and so on, but it's in the next few years here. Most of those sponsors do have some types of patient assistance programs you can inquire about, but I think it's very important, that I think we've had pretty good success at getting most insurance companies to cover them. I think the important thing is, if you're ever talking to people who are involved in this or make policy, the focus tends to be on the cost of the drug. But, you know, I've showed you that the DOACs produced a 50% reduction in intracranial bleeding or strokes compared to warfarin. The
Yeah.
cost of rehabbing one stroke buys a lot of DOAC.
Yeah.
So if you actually do proper cost effectiveness analysis, and that's the issue with American healthcare, it's so siloed that we tend to focus on one thing, which is cost of the drug. But if you add in the cost of monitoring warfarin, the regular prothrombin times, blood taking, INR, all of that, you add in the cost of the bleeding events that occur more commonly, those have to be treated. If it's a major bleeding, it's could involve hospitalization. Even if it's not major bleeding, it could involve a follow-on investigations, a colonoscopy, an endoscopy, a scoping, imaging tests, various things. So when we look at the cost effectiveness of one approach to the other, DOACs win very clearly in those assessments, even by pretty rigorous agencies like the UK agencies and others, right, that have. So I think I know it's still a challenge, but I would hope that by this time, 10 years after their introduction, most of these insurance companies have got to a better place. You saw, and I want to thank you all. I mean, look at the value of the patient advocacy, because I think you were not inconsequential in getting CVS to change its mind about
right.
not stocking one of the DOACs, right?
And
And
that
that's
was
very
reversed.
important. Yep. So yeah, but it's not only the cost of the drug, it's the cost of treating people where the drug isn't effective, the cost of administering the medicine and monitoring it, all of those things, and the cost of treating the side effects. That's how we should evaluate properly these things.
Yeah, good point. Good point, Gary. Thank you.
Okay. So as usual, we have run over.
I'm
Gary,
sorry.
thank you. No, it's fascinating. Thank you so very much. You know, it's NBCA's job now to continue to provide updates on what's happening in this space, what's going on with the trials, and Todd and I will make sure that we are out communicating to the patient population. I think we have a few questions we didn't get to, but we will try to get to you folks after tonight's event, and we just want to thank everyone for attending, and we'll see you next month.
One question, I'm happy, you can share the slides, Leslie, if you want to.
Okay.
Yeah.
Great.
Okay.
Thanks a lot, Gary.
Thanks, everybody. Good night.
Thank you. Have a good evening, everyone.
Bye.